Okay, so these first two lectures of this class are definitely the longest. With yesterday's, well, yesterday being Friday, we went over the clinical lab studies, and now today's PowerPoint, slightly shorter. I did break it up into two sessions, so you can take a break or whatever. Also, so I could take a break in between recording it, and then also the files are smaller, so that always makes it go a little bit better when I'm uploading these, downloading. So this is for July 21st. This is the Tuesday. So we're looking at the X-ray PowerPoint here. All right. So just, the basics. And I know we've talked about this in regular patient assessment. So these first couple PowerPoints or lectures are basically somewhat review, a little bit deeper in content. Hopefully I can talk better today than I did the other day. But always good review. So when we're looking at chest x-rays or any type of x-ray, you're looking at this electromagnetic wave that actually radiates from a tube which an electric current has been passed. So and that's kind of what gives us the pictures. So the chest x-rays are generated then by placing a film next to the patient's thorax, obviously if we're doing a chest x-ray, which is probably the more common ones that we look at. Then the rays pass through the patient and then are absorbed by the film proportional to the density of the tissue that they pass through. So as we look at things and trying to identify structures on the X-ray, low density substances like air are going to appear dark or black on an X-ray. Okay, so that is called radiolucent. So we call that black color radiolucent because you're able to kind of see through it. The rays, the X-rays just go right through it, so they appear black on the film. And then radio opaque then is what we call the white color, and so those are the denser substances like your bone, tissue, fat, that kind of stuff, which actually absorb the X-rays. So then again, bone being your most dense, water being your less dense. Fat is mildly radiolucent. I mean, you can see, it comes up a little bit white, but then, or I'm sorry, a little bit dark. So the air or the X-ray can kind of go through it, but you can still kind of identify something there. And then air being very radiolucent, so your air will definitely be black on the film. All right, so different positions on X-raying. So a conventional X-ray is one like where you would actually go down to the X-ray area, to their department, and they would have you stand, the person there on the right. They're doing a PA film there, so it's posterior anterior, so it's going from the back through the front. So you have the camera basically to the back of the patient, and the film then is through the front of the patient, is on the front side. So magnification effect is minimized on the 6 feet one, more accurate results, and then so it's not as distorted. And then 4 feet you kind of have less accurate results. So, but unfortunately, a portable X-ray is what we have to utilize in the ICU setting if a patient's too unstable to go down for an X-ray. So if you think about a lamp being kind of an example of where you're looking at, okay, so if you put your hand between the lamp and a surface to create a shadow, the shadows become smaller and sharper as the hand moves farther away from the light source and closer to the surface. So that's kind of like the less accurate, more accurate kind of thing. So again, your PA film then is where the beam moves from the posterior to the anterior part. Your heart's going to look slightly smaller on this view. And then a lateral view would be a side X-ray. Okay, a lateral where you do like your left side is preferred against the cassette. So the cassette being the film. So you would turn with your left side facing the film and then your right side facing the machine. Left side is preferred due to this less cardiac magnification. Alright, so again, just kind of showing another example of the PA film there. So again, the X-ray source is behind the person, the film is in front of the person. But then you still put the X-ray up. So really, when you think about it, if you're looking at it that way, if you're looking at the film itself, and Victor and I were talking about this yesterday, we're like, yeah, it is kind of confusing if you overthink it a little bit. But so basically when you're viewing that film, okay, so you have the picture, and if the rays have come from the back to the front, I mean, you're looking kind of more at a posterior, I guess, image, because your left side obviously is on the right side of the picture itself. All right, big thing to know about this. This is the most common film that you're going to use to diagnose a pleural effusion. Okay, so you want a lateral decubitus film. So that is definitely a MRE question that comes up. So remembering that air tends to rise and then the fluid falls, so it's gravity dependent. You can actually see as little as about 25 to 50 mils, and I have that circled as an MRE question also. So you can see as little as 25 to 50 mils of pleural fluid. Okay. If you're looking for a right-sided pneumothorax, you should, or you're suspecting one, you should place again the patient on the left side because your air is going to rise. If you're looking for a right-sided pleural effusion, then you would put the patient on the right side because the fluid is gravity dependent. Alright, your apical lordic view is looking at the apices of your lungs, okay, so the top parts of your lungs. So they kind of have you, I've actually never seen this done, but I imagine if they take someone down and they're looking for a specific lesion or something, or they're suspecting something, I mean, they do your general film first, and then they would order special views if something looks suspicious. So they kind of have them kind of tip towards the machine a little bit, giving them a better view of the apices. And if you think of a type of disease that you are looking for in the apices, TB. So anybody who's doing the TB presentation, I can't remember off the top of my head, but that might be a good thing to add to your clinical sim thing, is ordering an apical lordic, or however you say it, view of an X-ray, a chest X-ray. That might, make you start thinking. So I think that'd be a really good idea to include. Okay, so oblique views then, kind of looking for pulmonary or mediastinal lesions, trying to find those different abnormalities. So on these ones, the patient is turned 45 degrees to either the left or the right of the anterior posterior or anterolateral portion of the chest against the film. So again, it's to help separate the pulmonary or the mediastinal lesions from the overlapping structures. So it's done to kind of help clarify the location of the abnormality. So a patient is turned again 45 degrees to either the left or the right, right or left anterolateral portion of the chest against the film. So kind of like tipped a little bit. Alright, expiratory films. Another MRE question. You're going to use an expiratory film to help you detect a pneumothorax, especially the smaller pneumothoraces, because they're a little bit harder to detect. So as the patient exhales, then the lung volume is reduced, but the pleural air volume remains the same. So we're able to hopefully detect that easier. And then your AP film is generally what's used for a portable chest X-ray, so that's what you're going to be seen in the ICU, and for patients that generally, if they're on the floor, they'll try to take them down to the X-ray. They'll wheel them, down in their cart or wheelchair or whatever. But AP films are often used. Mainly, the most common reason is for line placement after intubation, line placement like central lines, NG possibly if there's a question as to whether or not it's really there. A quick look to see if they really might have a pneumothorax, if there's any other change in condition going on. There's more magnification artifact. You always have to kind of get the X-ray people are really good about it. I mean, they know what to do when they come up there and set up their machine and stuff, but try to get some of the leads kind of to the side a little bit. I mean, the actual monitoring electrodes need to stay where they are, but if you can kind of move the leads out of the way and try to get as much things that are going to create artifact, like your vent circuit, sometimes they'll want that kind of lifted up to the side, like so that it's not in the way, because especially if it's on a heated wire circuit, you're going to be able to see those wires on the X-ray, so they're a little bit harder to interpret. Alright, this is a just kind of a reference page on chest X-rays, on looking at the different landmarks. And this is actually right straight out of your textbook, this particular slide. So this is on page 201 in your textbook. So again, this is a posterior anterior projection of the chest, kind of showing definitely showing the trachea there as number 1, your right main stem as being number 2, your left main stem number 3, your pulmonary artery there is number 4. Number 5 is showing your right interlobar artery. 6 is, I'm sorry, that's 6. Your right interlobar artery. Your right upper lobe pulmonary artery is 5. And then your right lower and middle lobe vein being 7. Now, you're not expected to really know these on films. I mean, you can see it's just vasculature, okay? It's basically, you can see the blood vessels is what all that kind of haziness is there. Able to identify the carina, the clavicles, whether you're in a main stem bronchus with intubation. But I mean, it is kind of cool to know where all these things are. Your aortic knob then being 8, so that's kind of like that fatter white part there on the left. Your superior vena cava being 9. And then keeping in mind that when we're doing a intubation, we want to make sure that the excuse me, that the ET tube is about 3 to 5 centimeters above the carina after you're intubating. So that's generally between, the carina is generally located between the space of T4 and T5. Okay, so if you find a thoracic vertebrae between T4 and T5 is where the carina is located. Okay, so I do think that is actually a test or MRE question or test question. And then this being the lateral view, the things that you can identify here. Again, trachea is number 1, the right main stem being number 2. So this would be a left lateral, so you're looking at the left side. Left main bronchus number 3, because the front of the chest then would be on the left side of the film that you're looking at, where it says body of the sternum and the manubrium. The left interlobar artery 4, aortic arch again would be 8. Just looking at some of the bigger ones. 9, then being your inferior vena cava. So again, trying to help diagnose if there's any haziness or blunted. You want to make sure that you have that you can see the costophrenic angles to make sure that those are visible. Otherwise, you have atelectasis or possibly a pleural fusion. I mean, generally, the presentation of the patient kind of helps give you the clue, and then the X-ray, and then you decide whether you need to do further films or different images, basically. Okay, so again, just kind of a little review again there of the differences between the PA and the AP views. So thinking about different things that you would use for a chest X-ray, or indications. Why would you get a chest X-ray? So, I'm sorry. I obviously need more coffee this morning. So, indications for X-ray. So what are we looking for? Well, a lot of times we do it after positioning an ET tube or different line placements, like I mentioned. We're looking to see if the appropriate therapy has been ordered or is effective, the effectiveness of therapy, determine any type of lung alterations to see what's going on, if they have a pneumo or a pneumonia, and watching progression of disease. So especially in the ICU, if there's like an acute change going on, like you're doing your vent check and your airway pressures have gone up and your volumes have dropped down, and you're listening to their lungs and you don't hear any breath sounds like in the right upper lobe, or and you've ruled out that they don't need to be suctioned, and you've checked your circuit and you've done everything else, it might be a good idea to get a chest X-ray. Obviously, if you should always be documenting when you're doing your vent checks where your ET tube is placed, so you have an idea, so 24 at the teeth or whatever. But if there's any uncertainty, if the tube moved and you're having trouble with your volumes, definitely get an X-ray. If they're spiking a fever, their secretions have changed in color, in amount, having a hard time oxygenating, those are also indications for a chest X-ray. So sometimes we kind of help get the ball rolling on that. So again, treatment should not be delayed. So if you're really suspecting pneumothorax, for example, you should not delay while the images are being interpreted. The great thing now with our X-ray ability is that if they come up to do an X-ray, and especially if it's something that needs an intervention by a physician, like a chest tube put in, often they are usually there. And when they do the X-ray now, they have like a little computer screen that's right on their machine that's able to give them a really quick, it's a small view, but a really quick view as to some really gross abnormalities that are going on. So they don't necessarily have to wait for it to be officially interpreted to make a decision on treatment. I don't know if I told you guys the story. I may have, but I had a patient years ago over at Lutheran that had I was listening to him. I probably did tell you guys this in patient assessment, but I was listening to his lungs. His airway pressures were high. Back then we were using tidal volumes of like 900, and I heard nothing on his left side. I'm like, he has a pneumo. There's no doubt that he has a pneumo. So I went ahead and turned down his tidal volume to about half, probably about 450 or 500, and then I called the physician that was on call, because it was during the night, middle of the night, and he hung up on me. He got mad. He's like, put him back on his other tidal volume. And I'm like, okay. So I did not do that, because I knew it would do more harm, and I knew that position could be sometimes a little difficult. So they did do an X-ray, and ER came up, and they put a chest tube in. So I was right. But so go with your gut. All right, so again, some other things there, you know, a cough, especially if you're, you know, you come in for a workup, you know, at the clinic or something, and you've had this cough, or you're coughing up a little bit of blood, unexplained dyspnea, you've had a fever and it's not going away. I mean, there's all different scenarios. I mean, I think about, you know, inpatient kind of stuff, but outpatient things too, as far as, you know, why they would order a chest X-ray, excuse me. Obviously, change in speed of production, whether it be color or amount. Having chest pain, that is been ruled out by any cardiac issues. That might definitely be an indication for a chest X-ray. All right, so this, I think, is on page 222. I have in Wilkins, which is, I'm probably quoting, yeah, the 7th edition, but it's on your what is it, chapter 10, and Wilkins is your, and I would highly suggest you read this chapter. I sure hope this recording turns out okay. My voice is kind of funny. I would highly suggest that you read chapter 10 in Wilkins. Read your book. So a CVP is generally placed in the right or the left subclavian or the jugular vein, and it rests right above the superior vena cava, and it settles into the right atrium. Okay, so we want to make sure that we haven't given a pneumo. So we want to make sure the CVP is indeed in the right place. So that's a reason why you would do a chest X-ray. Again, with inserting a Swan-Ganz or a pulmonary artery catheter, post-procedure bronchoscopy, just to make sure you didn't, you know, cause any type of pneumothoraces. Obviously intubation, remembering intubation again about 3 to 5, 3 to 6 above the carina, between T4 and T5. Sometimes for an NG tube placement, an AP X-ray is used. A lot of times, if it's a patient that's getting intubated, they'll also put the NG tube in shortly thereafter, and so then they'll just wait till everything is put in, you know, especially if they're a sick patient, they're deteriorating their status, we've had to intubate them, and now they put an NG, and now they decide to put a central line in. They'll kind of wait till all that's done, and then they'll just do one X-ray, unless there's some kind of obvious problem. But sometimes the NG tubes can go down the wrong hole, especially they kind of tend to want to follow the ET tube, so you want to make sure that the nurse did not put it into the trachea. If they do, and then they hook it up to suction, you're not going to get your tidal volumes back. Sometimes they get coiled up, as you can kind of see in this one. Sometimes they just get coiled up in the back of the throat, so always good to make sure the tube's in the right place. Again, chest tubes, making sure that the lung has reinflated, at least somewhat has improved. It's not going to necessarily reinflate immediately, especially if there's fluid in there that they need to drain to, but just to make sure that the chest tube's been inserted in the right place. To diagnose for a pneumonia, in this case here we have a right lower lobe pneumonia. You can see your costophrenic angles here on your right side, the right side of the patient, the left side of the picture, are kind of obscured here, and you can't really make out the definition of the lung itself and the diaphragm. Other things that helps diagnose are a silhouette sign. So I'm going to define a silhouette sign. So it's basically looking to see if there is a pulmonary infiltrate in an area where there's other thoracic structures. So sometimes it's really hard to see if there's something going on, because normally, I mean, and the technique of the film makes a difference too, as well as how penetrated it is. So if it's like an over-penetrated film or under-penetrated film, but that's, you know, technique that the X-ray tech is kind of you know, watching for and in charge of. So if they have to do another film, sometimes it's just, you know, there's too much artifact, or it just wasn't a good quality film. So normally there's a significant difference in the density with sharp borders in the mediastinal-like area. So you're able to, you know, tell the difference between tissue and maybe an infiltrate and bones. But in the lung tissue, especially around the heart or the diaphragm, sometimes it's hard to differentiate. So if the lung tissue is in contact then with the heart or diaphragm, and there's a consolidation, like a pneumonia, the contrast in the densities is lost and the borders are blurred. So when they have that, when it appears that way, it's called a silhouette sign. Okay, so there's a silhouette sign kind of indicating that there's probably some type of a consolidation, a pneumonia in that area. So the infiltrate that obliterates the heart border or diaphragm, generally in the anterior segments of the lungs. And then a air bronchiogram. Generally, the intrapulmonary bronchi are not visible because they contain air and then they're surrounded by air. So there's really no differentiation. You know what I mean? Differentiation. You can't see a difference. However, if the bronchi are surrounded by like consolidated alveoli, like they have a pneumonia, then they become visible because the air within the lumina stand out in contrast to that surrounding consolidation or fluid. So diseases that actually that consolidate both the lung tissue and fill the airways won't produce bronchograms, air bronchiograms. But if you have the situation where the air in the bronchi stand out against the surrounding tissue that's consolidated, then you'll have these air bronchiograms. And there are some different examples in your textbook, and I think this one might have came from your book. You kind of can sort of see it here. It's on this left side. It almost looks like a little tube or like a little straw where there's the air is kind of surrounded by like a white. So it kind of gives it that definition. I think that was the word I was looking for, definition. Okay, so make sure you know air bronchiograms, make sure you know silhouette sign. Atelectasis, of course, is something that we see quite a bit, caused by many different things. Compressive atelectasis, so you have a pleural effusion or a pneumothorax or hemothorax, any space occupying lesion that actually kind of squishes down the lung tissue. If you have a severe enough atelectasis, you'll actually have a mediastinal shift because it's actually compressing on the mediastinum area and would be pushed towards the unaffected side. So the affected side would be pushing it towards the unaffected side. Obstructive atelectasis, where you actually have some kind of a blockage in the airway, so ventilation cannot get beyond that blockage. A tumor, a foreign body, mucus plugging could be reasons. And then post-op atelectasis we see quite a bit of. It's just kind of micro-atelectasis, sometimes depending on what the procedure that was done, but just overall in general, if it's been like a belly surgery or a chest surgery, either way, they're not taking deep enough breaths. It's generally associated with pain. They're not able, and that's why it's so important post-op to see our patients, to instruct them on how to, you know, instead of spirometer is something I don't think you'll ever see go away, even though they say it, you know, it doesn't in the long run. But I think it's just the idea that it's sitting there next to the bedside, people see it, and whether they can, you know, hopefully use it or just remember to take big breaths, get out of bed. I mean, you'd be surprised, some people, they just don't want to move, they just want to lay there, and you know, they you know, only halfway breathe, and then they develop a pneumonia, or their oxygen needs go up because they've developed atelectasis, or they're not moving air. So getting them out of bed, getting them walking, you just naturally take deeper breaths in. PEP therapy is another thing that we can do to help prevent that. So the volume, so your chest x-ray, you have a mediastinal shift toward the affected area. I'm kind of got to think about that for a minute. Hold on. Okay, on further investigation here, so I guess they're talking about a fairly large amount of atelectasis, so it's not so much the compression part, but if it's like you have a lobe that has collapsed, then your shift of the mediastinum area is going to go towards the affected side because it's going to try to take up that empty space. So we're talking like entire segments or lobes that have collapsed. I'm thinking more that's, so the shift of the trachea and heart and major thoracic vessels towards the affected side may be seen with like lobar atelectasis, so like a whole lobe has become atelectatic. So I guess slash out my other statement that I said. All right, so how are these patients going to present, especially if they have a large amount of atelectatic area? They're going to obviously have decreased breath sounds, rapid shallow breathing, decreased to absent vocal phrematus, decreased resonance to percussion. They may present with cyanosis. So I'm looking at your new book now, the 8th edition, and so this is being covered on pages 203 and 204 in your textbook. All right, so pneumothorax. A pneumothorax can definitely cause atelectasis. The air is entering the pleural space, or sometimes it's fluid. That would be called a hemothorax, especially if it's blood. Probably the more common ones are pleural effusion, can even cause a pneumothorax. But your lung is basically collapsed. So if you have a large pneumothorax, for example, where the whole lung is collapsed, it is considered emergent, and you want to get a chest tube in as soon as possible. So you can kind of see here by your little arrows on the right side of your arrows there on the pointy, you can kind of see that lung border there and how you have more air on the outside part. Tension pneumo. So actually both of these images are from your textbook. So here is a tension pneumothorax, sometimes caused from positive pressure ventilation. So again, the chest wall, you're going to have reduction on the affected side, so it's going to be kind of, it's not obviously going to inflate, or you're not going to, you do that chest wall expansion thing with your hands, you're not going to see that movement on that side of the chest. Obviously decreased or loss of breath sounds on the affected side, increased resonance because you're just basically going to have air there. They could be tachycardic. It could also affect their cardiac output because of that increased pressure of the tension pneumothorax. So hypotension. They could possibly be cyanotic and absent whispered voice sounds and tactile phrematus. All right, hyperinflation. This is definitely a thing that we see a fair amount with our COPD patients. So in our obstructive lung disease and also with our asthmatics, we have an increased AP diameter, a large retrosternal airspace, so in between the sternum and the lungs itself, there's an increased space. Flattening of the diaphragm. So on the appearance, physical findings, they're going to have this kind of more barrel-shaped chest, increased resonance to percussion, limited motion of the low set diaphragms because they're already hyperinflated, so they're really not moving that much. Some wheezing, decreased breath sounds. They could have a rapid respiratory rate, but they could also have kind of that, at the same time, a prolonged expiratory phase, pursed lip breathing, tripod breathing, and use of those accessory muscles. And here's the different images that are coming from your textbook on page 205, where you can kind of see that flattened diaphragm on both sides, this increased AP diameter front to back, and then that increased retrosternal space. That large retrosternal airspace, really right here where it says the double A. Can you kind of see that? All right, interstitial lung disease. Again, this chapter moves kind of fast. So interstitial lung disease, many different causes. And then there's also idiopathic interstitial lung disease, which they really have no idea why you have it. But some of the more common things are exposures can definitely cause it. So exposures like to asbestos, silicosis, radiation, different types of dust, rheumatoid arthritis sometimes, lupus, they can develop interstitial lung disease. Sarcoidosis is kind of more idiopathic. Pulmonary fibrosis, also idiopathic interstitial lung disease or idiopathic pulmonary fibrosis. Kind of the pulmonary fibrosis falls underneath the interstitial lung disease. So basically there's some type of scarring or fibrotic tissue that's developed. This, whatever it is, whatever exposure, whatever they've had, if it's an illness, activates the patient's immune system and creates the scarring or the fibrosis. It can develop over a period of months to years. So that's, I think, the hard thing about it, is that you're really not sure when it all started or what might have caused it, because it's not like a really an acute thing that comes on. So sarcoidosis is going to present more with the large hilar and paratracheal lymph nodes. Asbestosis is going to have more calcified pleural or diaphragmatic nodules. End stage pulmonary fibrosis, you're going to see like these honeycomb cavities, kind of like they've lost that, their alveolar capillary kind of membrane has kind of been sort of eaten away or disintegrated. And then bronchiectasis, you're going to see larger air bronchograms with those thick walls. I'm trying to see here what. So if you look at 206 and 207, you have a couple different things. You have more air bronchograms, and actually that's the one that we looked at earlier. A lot of times these types of patients are going to need maybe like like an EBIS or a different type of bronchoscopy to actually do, like, get some lung tissue to actually diagnose to see what they are. Occasionally they may have to do a video assisted thoracoscopy, or they call it a VATS, where they actually have to do kind of more of an open lung biopsy to diagnose these patients. Okay, this is again in your textbook. This is on page 206. Again, listing some of the different causes, and kind of a picture here of what the severe interstitial fibrosis could look like. Unfortunately, this is a really actually good picture of your trachea here, and you can see the carina. You can definitely see the right and left main stem. That's pretty cool. But unfortunately for these patients, it's just something they end up having to live with. I know steroids is part of their therapy to try to keep the inflammation down, but there's really nothing they can really do for these people. If it gets really bad, probably a lung transplant would be the best option. Okay, so that is part 1, and I'm going to take a little break and we'll do part 2.